background rules. So again, we'll post this to the DSS YouTube channel, and materials will be posted on the website. Please mute yourself if you're not speaking. The use of chat is just for Zoom technical audio issues. There's a Q&A feature. If you click on more, there's 3 dots there that should be there. And you should see that there's a Q&A feature located. If it's not under the more, I see it right there. You can click it and put any questions in there, and we'll try to answer them both in writing as well as verbally, depending on the how many and when they come in. And thanks, Kim, for posting that in there. Next slide. So our agenda is just some program status updates, things in response to feedback, additional resource documents, and then time for Q&A. So all along, feel free to jump in and ask those questions. Today, Fatmata Williams is at a conference. She is co-lead on this on the DSS side. And so we'll just have myself, our broader DSS team, Mercer team, and our FCG team as well. So just as a reminder, we've already announced this, but our revised launch date is now January 1st, 2025. We pushed this back from September 1st. We've heard a lot of very helpful feedback from probably many of you, as well as other providers and provider offices and teams about some technical concerns, as well as a few other concerns that we wanted to make sure we had time to digest, potentially address, or at least reflect on and get back to all of you. And so we're taking the time. We want to make sure we can answer questions as well as provide resources and guidance based on stakeholder feedback. So January 1st, mark your calendars. We are well on our way to launching. Next slide. So program status update, we reviewed this at prior forums. I'll just note kind of current priorities and then upcoming. So kind of consideration of program refinement. So that's been ongoing, kind of, you'll hear about that today. Updated FAQ, there's a quality measure reference guide that's now out, billing example, and then we're working with CMS for state plan amendment approval. There'll also be provider bulletins on payment policies and processes upcoming. You'll see final performance year case rates upcoming, as well as performance year provider reports. And just as a note, on that last slide at the bottom, there is the website, where that's the link. If you search for CT DSS Husky Maternity Bundle, you'll also be able to find the webpage as well that way. So this is just kind of an overview of the response to feedback. So we have had several June and July forums and heard some questions from you all as well as other providers. And so we spent time considering them and thinking about some of those less substantial technical adjustments as well as the larger substantial programmatic changes. And so we have a general approach and some of the things we are still working on. But today, the things we're going to talk about is case rate development, program monitoring, attributing costs to MFM providers, family medicine exclusion, billing for members with TPL, third-party liability coverage, and case rate services. Next slide. So we discussed this previously, and there were some questions about this at the last forum and came up subsequently, but this is really pertains to the case rate. And so one of the fundamental reasons we developed the case rate methodology and the program overall is really ensuring that members have access to affordable, high-quality care, and key to value that underpins all Husky Health programs. So the question here was, one of the asks that were made to us was, could there be a reconciliation to fee-for-service from the case rate? The case rate is paid on a monthly basis once it's been triggered. And there's been concerns raised that the case rate may be inadequate to meet fee-for-service demands. We have carefully discussed this as well as thought about it in terms of federal authority or other state budget constraints, and would require the state to conduct an upside and downside reconciliation if we were to do that. So that would, in our case, the other thing on the next bullet you'll note is that we anticipate additional dollars through the case rate going out the door. So in state fiscal year 25, that's $4.5 million. That may be slightly adjusted downwards, and that this was prior to the delay in launch. But in state fiscal year 26, $6.2 million and $6.3 million in state fiscal year 27. That's additional money that's currently not going out in terms of fee-for-service payments. So we anticipate additional dollars going to providers. And if we were to do a upside and downside reconciliation, that actually could decrease some of the payments to providers, which we think would undermine some of the goals of the program. There'll also be additional dollars that are going out for the lactation support PMPM. So there's add-on payments to the case rate. The case rates are calculated based on historical fee-for-service utilization. The additional dollars is $7 per month as part of that goes on top of the case rate. There's also upside-only shared savings payments in addition to that case rate add-on. So that we anticipate significant dollars going to providers as part of this program, and are very hopeful that this will help reward providers for high quality care that we expect to continue to be delivered and enhanced through this program. Next slide. So one of the questions I think is like, how are we going to monitor this? And because I think that the concerns are understandable, and we're changing significantly how we're paying for care, and how do we make sure that members have access, practice revenue is stable, and monitoring what those billing patterns look. So again, to date, we've done a very rigorous evaluation to create the case rate in the first place, just to look at historical utilization patterns, create a code set for which the case rate's made up of from those historical fee-for-service payments. And then we've done several different time series to have a case rate draft, and we'll have an updated one that's more reflective of current utilization patterns before January 1, when we launched the bundle. In terms of monitoring that, now that we've already been working through that case rate development, is really monitoring over the course of this first year of the program launch, in terms of our members having access, what's happening with practice revenue when we think about case rate versus fee-for-service billing, and then just general billing patterns that will be zero paid as well as paid fee-for-service after implementation. So this is something that we care deeply about. We understand this is important for a lot of providers, and it's something we're going to be monitoring very closely. There is a plan to rebase cases, not more than once annually. So case rate rebasing is baked into this program. We'll be looking at risk as well as trend factors to really account for changes in the risk mix or service delivery over time at that provider level. Next slide. So member MFM and provider inclusion, this has come up several times. This is something we discussed at the last provider forum, and we have gone back and thought about this more and looked at it. And so we've kind of reaffirmed the decision to include MFM care within the maternity bundle for year one. We think one is to align incentives across the OB provider specialties. We want to ensure inclusion of higher risk patients in the program. We know that MFM providers are often taking care of those higher risk members, and we really tried to reduce some complexity in the design and operations related to MFM billing and the impact of attribution changes. So what does that mean for providers? So if there's in-house MFM services, that's provided within the tax ID number, so the TIN, that gets reimbursed by the case rate. That those historical fee-for-service claim and billing will be brought into that case rate as reflected. For external MFM providers that are participating in the maternity bundle, so what could happen is if there's two provider groups, so one TIN group that is taking primary attribution of the care, and that person's billing, and they're triggering the case rate, that case rate will be paid to that non-MFM OB provider. They refer them to a MFM provider that's in a separate TIN that is eligible. That MFM provider can also receive that case rate as well, as long as there is a triggerable event happening each month. So say in September, I'm seeing the person as a general OB. I refer them in October. They're seen in October by an MFM provider. I'm still going to see them monthly. As long as I'm billing triggering events in the MFM provider, we both can get paid that case rate on a monthly basis. So just to say, and I see, there's a hand up here. So just want to.
Hi, Brad. Josh Coppell. I'm sorry to interrupt the flow.
Not a problem at all.
Q&A is turned off. So I tried to type questions in, but the Q&A.
Thanks for letting us know that. Kim, if you could take a look on that, but please go ahead and please interrupt.
My question about this slide is that MFMs bill with a different taxonomy code than general OBGYN. So that bullet is not correct. We don't bill under the same specialty type. We bill under a subspecialty type.
Are you talking about the bullet that says the provider with the within the tax ID?
Under provider implications. Since MFM is an OBGYN specialty, MFM providers typically bill under the OBGYN billing provider specialty type. We use a different taxonomy code. And so we can be distinguished throughout prenatal care and postpartum care by the taxonomy code.
Yeah, we actually have a sub, and actually I think Sandy might be on, who can provide a more technical response here in terms of how it's characterized in the system. But we are able to identify MFM providers. So just to say, yes, we are able to see them as a subspecialty. But Sandy, do you want to, if you're on, provide a more nuanced response?
Okay, yes. So while we do receive the specialty, we don't enroll them under the specialty that they're enrolled in is under the OBGYN. We know the taxonomy description is MFM. We've mapped those taxonomies for MFM under the OBGYN specialty.
Right, so that's a choice by DSS, but not an intrinsic reason why MFM must be included. That's your choice to include MFM as if we were specialty OBGYNs rather than a subspecialty.
Well, I think we recognize it's a subspecialty, if that makes, I think this is a little bit more just how the technical system, how the system functions, if that makes sense, rather than saying we recognize that MFM is a subspecialty provider of OBGYN.
Right, and this is the point that a number of us have been trying to make all along, that we should be considered different from specialty OBGYNs. But I've obviously lost that argument several times. It's just seeing it over and over again, I have to raise the point.
Yeah, and I don't know if we're saying anything that's actually that different in terms of just recognizing that MFM providers are a subspecialty. There's different training. Some MFM we know provide ongoing prenatal and postpartum care, and some MFM providers are really providing just consultative care as well. And we know there's different ways of actually practicing MFM care as well within Connecticut, where we've seen that and talked to different providers.
Right, and it's more intensive care, but I guess we hope that'll come out. I'm not sure we've seen the new case rates.
Oh, sorry.
I'm not sure we've seen the new case rates that you said were released in August.
They were actually released in August. There will be news case rates coming out, but we did provide additional data for providers in terms of those case rates. So some numerator denominators. So that should be at the TIN level. We did provide those in mid-August. I don't know the exact date, but each TIN should have additional data that was provided. But we will be releasing subsequently a new case rate that will be updated as well. So let me take a pause there.
Thank you.
Did that actually answer your question? I just want to make sure.
Brad, this is something that you and I are never going to agree on, I'm afraid. I mean,
understood.
We come at this as a practice that does full spectrum OBGYN care, and it's different than other practices and much more intensive. So if it works out that our case rate supports the level of patients that we take care of, great. And I'm sure you can understand that many people are concerned about whether that's going to actually pan out. We'll see.
Yeah, I think that was the goal of developing a TIN-specific case rate, was to make sure it did reflect that, provide that nuance that each practice may be providing different levels of service to different types of members. And really, instead of having one single case rate that applies across the state.
We have multiple practices within our TIN, some of which are low risk.
Yeah, and totally understand some of the challenges. Just so you have a sense, like I think in a world where there was opportunities to do it at maybe even a more granular level, that would have been probably a consideration. But based on some of the limitations that we face, based on existing our existing infrastructure, that really isn't feasible to do it at a more granular than a TIN level. But I understand that even within TINs, there's obviously different. We know there's different provider types within TINs as well, especially for larger organizations. Just on that, we are looking to provide additional data specifically about MFM providers. So this next slide actually jumps in, and I see Kim Montero may want to jump in here with another question, so I'll get to you just a second. But in terms of attributing cost to MFM providers, even at that TIN level, understanding that that some providers will have MFM practices that underneath their TIN that might be separate from a lower risk OB, is actually trying to provide additional information how that case rate revenue would be allocated, or how it's made up of that case rate, to allow for more internal operationalizing of that accounting practice. So we are looking to do that so that providers have that additional level of data that can help with kind of operationalizing it at that TIN level. Kim, did you want to jump in on something related?
No, that makes a lot of sense. I think you already answered my question. Thank you.
I saw, I think Amy Gagliera had a hand up.
Yes, I do have a question about maternal fetal medicine. Whether the maternal fetal medicine provider is in the TIN or in a separate TIN, would the case rate be higher than if they were billing fee for service, which is higher, as you just said, than a regular OBGYN rate would be because of the higher risk patient population?
Well, necessarily the rates wouldn't be different, but we anticipate that MFM providers may be providing higher cost services or providing more units of service rather than necessarily, if you bill a 99213 as a MFM provider versus that would not necessarily be different. It's more based off of the types of services needed to provide to we would anticipate additional complexity of members they may be seeing, if that makes sense.
So if the code they provided as fee for service was a high acuity code for a service they were giving, would the fee for service rate be higher or lower or the same as the case rate that they're being put into?
Yeah, like if they build a 99215 versus a 99213 type of situation?
Whichever is higher.
Yeah, 99215 would be higher. So if they're billing higher, so we are taking historical utilization patterns, and so whatever that's reflective of, we bake that into a case rate moving forward with, and so if you are billing mostly again higher service, so for example higher levels of service is what we would think of in terms of like your typical E&M or evaluation and management codes from like 99212 to 99215. If we're billing more to 99215s, that's reflective in the case rate. And again, this is at TIN level.
I get that, but would the case rate be different then based on the historical data and averaging that out? Would a maternal fetal medicine case rate be higher than the OBGYN?
It really would depend on the type of care and how it's hard to say. It's going to depend a lot on, again, it depends on that historical billing patterns. So if you're providing consultative care only and you're not taking full account, again, so our case rate includes prenatal to postpartum, including professional delivery services that's provided at that TIN level. If you're seeing someone for diabetes management as an MFM provider, you may not be providing that full spectrum and high as many services. And so your actual, the amount that goes into the case rate may be smaller than it might be for an OBGYN that's doing deliveries or C-sections, for example. So it's impossible to say without looking at each provider level.
I was just wondering what went into the decision of having them as case rate rather than fee for service.
It's mostly that we know that a lot of MFM providers do provide support or primary maternal health care to those higher risk members. And we wanted to make sure that the case rate, we purposely have designed this in a way, hopefully, to include to incentivize providers to have more accountability for the outcomes. And I know as a provider myself, I know we all care, but sometimes the incentives aren't always aligned for us to do that. And so part of the goal here is to align that incentive, especially for our highest risk members. And so that's, I think you were part of probably some of those conversations probably a couple of years ago, actually, as part of our advisory council, was we wanted to make sure that part of this development included those highest risk members. And so that definitely was part of that decision making, that we don't want to exclude those higher risk members, as a lot of value-based payment arrangements sometimes do. They actually exclude some of those higher risk members. We've tried to say, as much as possible, we want to include them as part of this, which would mean including MFM providers, because they're often taking care of those higher risk members.
Part of that, I would assume, the incentivizing of the higher risk providers would be the case rate.
Yeah, and I mean, so again, looking at how we've developed this is, if you look back over a period of time, whatever payments were made to those providers, that's how we built this case rate. We have a set of codes that are used. We then take that utilization, taking those codes in the utilization history, and we build out a case rate based off of that. So if you have providers that have provided more utilization because of higher need members or higher levels of service, that's reflected in the case rate.
What I'm unclear about is the case rate the same for every visit they do, or is the case rate based on the code, the acuity of the visit?
The case, in terms of how it's actually paid, is the case rate's a monthly payment that's inclusive of all those codes. So if you see someone and you bill a E&M code and you've already triggered it. So say I see someone and let's pretend I'm a OBGYN. I
understand that, Brad, but it would seem to be then the incentive would be over a monthly period. They would be getting, they'd be incentivized with a better payment than if they were a fee for service.
I'm not sure I'm completely following. Does anyone else, Tiffany or Sandy, maybe I'm missing it?
I was just going to say I think the model we have is that the case rate is going to stay the same for a whole year per month, and that it would be reviewed the next year based on the claim volume that you've submitted over the course of, the first year. But that we aren't looking at the acuity case by case and changing the case rate month by month.
What is changed is the target price, so that affects your shared savings calculation. So the target price does have adjustments built into that. What we would probably say is that that your case rate is reflective of existing risk in the population and existing service utilization, as best that reflects it without additional change, if that makes sense. So that's where that adjustment in terms of TIN level provider case rate would be. But on the back end, on the target price, where we help set a target price that is risk adjusted, both medically and socially risk adjusted, that is accounted for in terms of how we calculate the shared savings. Grace, is there anything you want to add that that whatever I said need to be clarified from a technical perspective?
No, you covered it, Dr. Richards. So basically the case rate will be flat for the year every month, regardless of the actual acuity of services provided. But on an annual basis, we do risk adjustment to the target price to reflect the members that each provider take care of during that year, comparing to their prior year, and adjust the target price, meaning episode price accordingly, and then compare to the actual cost or actual payments, and then that will be the foundation of the incentive payments at the end. But also, like Sandy was saying, on the less frequent than once a year basis, we'll reevaluate the historical claims submitted, and then reevaluate and readjust the case rate for the future year.
So the incentive is just so they can participate in the shared savings is the incentive.
I will say there are some incentive, like the episode cost, the final reconciliation. I won't call it incentive per se, but it's like, if a provider happens to take care of or tend to take care of a sicker patient, or even year over year, they're taking care of more cases of the sicker patient, then they will have more financial reward from that regard.
Any other clarification on that?
I just want to add one thing, maybe looping back to the prior question about taxonomy. Like Sandy was saying, basically, there's different fields on the claim. There's taxonomy, which could be multiple taxonomy under the same specialty. So that's the reason how we kind of include the MFM is we're only looking at the billing specialty in which there's different taxonomy, and one of that is MFM. So they're two different fields. They're not mutually exclusive.
There was one question in our Q&A about lactation services. What is the definition of these services that providers will need to provide to members in order to receive the additional $7 PMPM? I'll note lactation services, or the lactation add-on payment, is going to be provided automatically on top of the case rate. Once the case rate is triggered, there's going to be no true up or reconciliation process to take back any of those dollars. And I'll also put in a link to the website where we do post additional description about what services would count as lactation services in our technical specifications document.
Thanks, Tiffany. And thanks, Grace. In terms of family medicine, this came up from a few groups that asked about family medicine providers being included. And as we looked at both family medicine physicians as well as family nurse practitioners, and found that in terms of actual maternal health services, and also I should also note we reached out to a few providers. So thank you if any of you are on who answered questions from us. And it appears that really family medicine providers and FNP, as well as family medicine physicians, may be providing some level of obstetrics care, but not to a point that they're actually providing it to be included as part of the bundle. And so after doing a little bit more claims analysis and discussion, we are planning on excluding family medicine physicians as well as FNPs, just to make it really clear. The reason for that is some groups have family physicians and family nurse practitioners that are providing what appears to be more primary care services, or maybe very light obstetric services that could get included as part of the case rate, or if they were billing, they would get zero paid. And because some TINs are very expansive in terms of the providers that are included, we wanted to avoid any confusion that could occur where a family medicine provider or FNP is providing services that's more primary care. They might be including a code as well as a diagnosis that typically would trigger, or that would just be included because it's on the zero paid claim list, and they wouldn't get paid for services that are actually not what we're including as part of the maternal health services. So all to say, we are excluding these provider type and specialties. Initially, we are looking to be inclusive. In other states, that family medicine providers, including FNPs and physicians, do more obstetrics care, but in Connecticut, it appears to be quite low, if barely existent at this time, based on at least providers that are in the Medicaid system. This may not account for providers outside of Medicaid. This is an update on billing for members with TPL, or third-party liability coverage. This came up in some of our conversations that we've had today with various providers, that third parties or non-Medicaid coverage is still utilizing the global code billing. And when Medicaid is also on, so someone may have private insurance through whatever reason, or they could have coverage that's through a partner, et cetera. Basically, Medicaid is a secondary payer, and we're getting crossover claims. And the concern that was raised is that, if someone has third-party paid coverage, and we're getting and we're actually, and Medicaid's getting these crossover claims where we pay, if there's an appropriate amount in between what the TPL paid and what we would pay that as a fee-for-service payment. And the providers are working towards planning on billing a global code. that it could create some confusion if we're paying a case rate and we're not paying that fee for service gap. And so what we've decided to say is that we will continue to pay anyone with a TPL paid amount in a fee for service manner, so that providers can focus on the primary insurance type as opposed to worrying about Medicaid and our rules on this. So all to say is, if someone has TPL, we will use the paid amount and use our standard fee for service payment process moving forward. Let me pause there. Sandy, anything you want to add on that? I know your expertise. I want to make sure I got that right.
No, I think that was correct. Anytime there's a TPL amount on the claim where the TPL paid greater than 0, we'll process that claim as a fee for service and not pay the case rate. If there's nothing billed on the claim, but if it's 0 and if it's not, there's no TPL even identified on the claim, and we have TPL in our system, we'll deny the claim for bill other insurance first.
Amy, I see your hand up.
So I have a question about the exclusion of family medicine. Was that based on the number of deliveries they provide? I know originally people were eligible based on the number of deliveries they did a year. So did you look at the hospitals that have family medicine providers and residency programs at the number of deliveries that they provided?
We looked at those who would be currently included at the 30 birth level. So we really looked at those who would meet that criteria at that 10 level. Again, not to say there's no family medicine providers that are doing any deliveries at all, but to be included, you have to meet the criteria of the 30 birth threshold. This might be something we have to change in the future. I just want to acknowledge that this is just kind of where we are now. We want to, because of our current system, it's very difficult to parse out some of this, especially if we included them. So again, we did look to see for those providers we are including as part of the maternity bundle providers, again, having 30 births or more attributed. We saw very little utilization outside of a few practices, which we clarified actually those family medicine providers weren't doing obstetrics care, they're actually doing primary care.
So I would argue not based on individual family medicine providers, but based on groups. I know of groups that are doing far more than 30 deliveries a year. So I just question at the accuracy of the data you're working under the assumption of.
Yeah, if you have, and Amy, if there's we're happy to take a look at this. But again, I think at least I'm not sure how they're structured or if they become accountable providers or if they're only doing the deliveries as opposed to the prenatal. I don't know the specifics, but at least based on the
doing
data.
Prenatal deliveries and postpartum care. So
yeah,
again, I think we've talked about that before, and I'm just surprised to see that that they're removed after they have been in. Just
based on what the data we're looking at, the 10 level, if you have specific providers, and we can actually look at that in our data just to see if there's something we're missing. So happy to look at it. If you don't mind circle around, we'd be happy to hear from you on that.
Thank you.
Thank you. Yeah, our goal is not to, again, we're trying to be, especially the family medicine provider, being inclusive was the goal from the beginning. But we realized that doing that actually, there's always a pro and con of doing various things. And in this case, it looked like for the included TINs meeting the threshold, it actually might cause more challenges because the family medicine providers globally seem to be providing services around primary care and not necessarily obstetrics. But again, we definitely want to take a look and think about that. So if there's specific providers that you're thinking about, Amy, happy to go back and we can double check and see if there's something we're missing. Again, maybe I don't know if there's reasons they're not included in the bundle for any reason, but we can take a closer look. So thank you.
One question in the Q&A before we move on, Brad. Is acuity being determined by coding throughout prenatal care, such as coding all problems managed at each prenatal visit, or is it determined by problems coded at the time of delivery, prenatal problems and delivery complications, i.e. how are providers communicating acuity to you.
Okay, great. So in terms of risk adjustment I might pass it over to Grace, who jumped on.
Yep. So I think the acuity is risk score. So basically, we have been using a risk model where we look at members' claim history and then put them into certain disease category or the category where they identify how many diseases has been identified, and then come up with a score which should represent or correlate. The score should represent how costly their cares are. So that's how we don't really look at particular claims, but more so an entire claim history for a certain period of time. Hopefully that answers the question.
And Alexandra, if you want to clarify, you're welcome to unmute.
Yeah. So I guess my question as a director of a resident clinic is, when you are looking at the claim history, right? Are you looking at my coding, like my diagnosis coding over the year for all of the patients that we're caring for within prenatal care and delivery and postpartum care? Are you looking at how often we're billing a problem visit in addition to coding or billing for like global care? Like, specifically, how as providers are we communicating that to you? Because we have to start putting these processes into place now.
I think so. That might be, I'm not too in the details for the risk adjustment, but I know I will recommend just bill as normal, how you usually bill for as in fee for service, so that we can see all the care that has happened throughout the period of time. So like, for instance, if this member, in addition to their maternal care, they also have some other health concerns. So obviously those those claims will be billed, will be reimbursed fee for service. So those also will be taken into factor.
Right. But with prenatal care, typically we don't do that, right? So like if we're seeing somebody who has history of chronic hypertension with chronic renal disease, this is just an example of a patient we currently have in our clinic, like hypertrophic cardiomyopathy and chlamydia, right? So all of these things at each visit, and especially in a clinic setting for our Medicaid patients, are dealt with at the time of their prenatal visit. So we're not billing all of these problem visits on top of their prenatal care. So that's kind of why I'm asking, like, do we need to complete, like that would require us to see them significantly more, which we can't because they have like transportation issues, etc. So that's like why I'm a little bit confused on like this answer.
Alexandra, I just want to understand your question a bit more clear. So you're saying sometimes when they are during prenatal care, they're normal, like, assuming they're not they were not pregnant, then they would have pursue more services, versus during prenatal period of time for various reasons, they might actually have less visits for other health concern. Is that the question?
Yeah, I mean, I've worked at a couple of practices, and I mean, maybe we're just an anomaly, but I don't really think so. So like when you're talking about the acuity of a patient and how costly their care is, right? Like that, to me, an acute patient or a complex patient is somebody who has multiple health problems that are making their pregnancy more complex, right?
Right.
So that is taking more of my time as a provider to do their actual prenatal visit. So instead of doing their prenatal visit in 15 minutes, it might take me half an hour or more. In addition, that person is seeing maternal fetal medicine for extra ultrasounds, etc., and non-stress tests. But then they also may be seeing, say, like their pulmonologist, their cardiologist, all of these things, which are not being captured in your review of their case rate, I would assume. So,
yeah.
So my question is like, when I'm caring for this patient as a primary OB and I am not billing for a problem visit when when I'm adjusting their like hypertensive medications at the time of their prenatal visit, but that still is a harder, more complex patient for me to care for.
Absolutely. Yes. So
how is that, what are you guys looking at in my billing and coding? And how do I need to adjust what I'm currently doing to make sure that's appropriately communicated in this first year?
Now I got your question. Thank you. So when we look at risk score, or another, stakeholder does a risk score, they don't just look at claims, the attributed TIN billed. They look at their entire history. So in your example, maybe they're seeking help from another specialist for their other health concern. That claims will be also captured when we define or when we calculate their risk score. So it's not just your maternal claims services are captured for the risk scoring. We look at all of their claim history from you, from someone, from hospital, from everything to capture their disease category. Okay. So for you, yeah, so like exactly like you said, there will be a corresponding to your maternal care when somebody is, has more health concern. So that is why the risk score applies to maternal care as well. So that makes perfect sense. But when we do the risk scoring, we don't just look at your claims or the services you provide. Yeah.
Are you looking at coding as well? So like another example would be like this patient should be seeing her cardiologist monthly during her pregnancy, but she doesn't have transportation, so therefore she is not. And I would say this applies to 75% of the patients in our population. So then that's not getting billed for, right? Like those services, even though she needs them, are not getting captured, which actually makes me taking care of her 10 times more complicated. So are you guys also looking at our code, like our diagnosis coding, or is it just additional billing that's outside of what we would consider like the historical like maternity bundle?
So I can take that question back to our experts on the risk scoring, but I don't want to misspeak here. We can get back to you on this question. Just we'll provide information on whether we looked at diagnosis code only, procedure code only, or we look at diagnosis code, procedure code. What kind of codes we look at to identify those health concerns or disease categories? We can get back to you on that.
Please get back to all of us, because not to take into account our coding, I put it in the Q&A, we may code 4 or 5 different medical complications that we're dealing with in the prenatal visits, in addition to what the other subspecialists are doing. I think really obscures some of the acuity of the patients we're taking care of. And we're handing you the information. I hope you'll use it.
Yeah, and I think the goal is to pull in those various pieces of data to help with the target price again. There is risk adjustment being made on that, so that is the goal, and we can try to be more explicit with a follow-up either in an FAQ or a subsequent forum, just to be more clear. But yeah, I think our goal is to try to capture that information. I think we can just be explicit about how it is going into, so we can tell you exactly what that looks like. Any other questions? Case rate. Is that Amy? You came off video. I don't know if you had a question you wanted to ask. I'm not sure if I saw a hand. I may have missed it. Oh, you're on mute. Oh, you're on mute, Amy.
I just want to support what Dr. West said. You may refer people out to endo and cardio and any kind of specialists, but when they don't go, you at the end are the one taking care of them visit after visit throughout the pregnancy. And so it would be helpful to know how those things are going to be accounted for.
Thanks for chiming in. In terms of case rate services, this came back as feedback as looking at what codes are being included as part of the case rate. And some of those are related to preventive pediatric and adult care. And so after internally reviewing and discussing, going to plan to exclude the specific codes from the case rate. Those are 99381 through 99397 for moving forward. It's a very small portion of services, but we just wanted to let folks know there was an adjustment, and this will be reflected up on the code list that we have on our website. So, and then additional resources are just some things that are out now for those who some of may have already seen it, but an updated program FAQ, so updated questions, some from many of you that we've been trying to make sure there's answers for. Quality measure reference guide, so more information about the quality measure slate and those reporting details. A billing example with a detailed example of how claims processing will work under the program, and the updated code list, again, reflecting those minor modifications that we just mentioned. And again, these are, you can find it on the DSS website, and we'll make sure to continue to include updated information on this. So just want to say, appreciate all the questions and engagement, knowing, that, there's important information that you all have that you share with us, and hopefully you can see that we are trying to be thoughtful and really consider the feedback we received along the way, acknowledging obviously we won't always change, but we do want to be thoughtful. In the long run, we hope that this program will lead to wins across the state, wins for providers, providing more resources and accountability in the long run that can help resource providers better and be able to act in a more comprehensive way for members, hopefully more helpful for members in reducing adverse outcomes in the long run, improving maternal morbidity as we pay differently, and hopefully get more dollars to providers to be able to make that behavior change that can help members make behavior change. And then hopefully really helpful for the state in the long run. We're understanding that we're hoping to see additional dollars to go out the door to providers, leading to improved outcomes, to improve the wellness of the state and the people in it. Acknowledging this is going to need to be going on. Some of you are engaging more recently with us on this. Some of you have been engaging for years, and we know this won't be, even after launch, this will need to be an ongoing conversation about what's working with this, what's not working, where there's problems. And I think just so you know, we are trying to listen to that feedback. When you tell us something, we're taking it seriously. We're looking at it. And we're trying to be really considerate. Again, we will have to draw a line in the sand at some point for programmatic changes. Just to be explicit, we need to launch this program. Again, we do anticipate year over year that this program will need to evolve, to change, improve, be responsive to the needs of the state, providers, and members. So any other questions? I don't know if I missed anything, Tiffany.
One just came through. Are there plans to allow OB practices to see and compare the case rates of other organizations in the state?
I think that I'm not sure we've actually explicitly stated that, but we will have to take that back and kind of decide what the plan is in terms of that. That is information that obviously we want to be mindful about sharing, but also want to be transparent as possible. Again, the goal here is we're trying to be relatively thoughtful about developing this care, or have been, where we are doing it at a provider-specific TIN level. And without getting into the details about every single case that's included, it's very difficult to explain why one case rate is going to be higher than lower. Again, just to recognize that there is shared savings at the end, and that case rate does go into that shared savings calculation. So if the case rate is slightly lower, then it may lead to more opportunities for shared savings. At the same time, we also recognize that shared savings payments are made after a period of time, and so there's some lag in that payment. So our goal is to make providers whole for how they're currently providing care to members and how they're currently practicing, acknowledging there is provider variability that exists in Connecticut. All right. Thank you all. We know we have a few follow-up items. We will plan on working on some responses. Amy, I know you mentioned there is a provider practice that you think maybe we're not considering, especially in the family medicine. Would welcome hearing from that. I don't know if it's the family medicine residency practice or not, but would definitely welcome hearing about that. We just want to make sure, again, we're trying to be responsive and engaging with providers and practices. I think many of you we've had meetings with. We welcome one-on-ones as needed as well. I think we have some scheduled already upcoming, but we welcome that continued engagement and questions. We know that this is only going to be successful as much as all of you are able to make it successful, and that we're reliant upon the providers to make changes based off of the incentives that we're putting together. And we know that this is not a small lift for many of you to change. And so we just want to acknowledge that and say that we do see the importance, the questions of you asking to making this program successful. And so we do welcome that. All right, thank you all. We appreciate. We'll be posting this again online on the YouTube channel. We do have another provider forum coming up next week as well. So if there's any other questions that you want to join, you're welcome to join for that one. Just make sure to sign up, and we'll anticipate getting additional information out to all of you as soon as we can. Thank you.
Thank you.